Well, you know, the issue of whether personalized medicine fits only in a tertiary setting or in a primary setting as well is an important one, because the reality of it is that it will impact all of us. Because the patient population really is variable in response to medicines, and because we want to get diagnostics more precise, over time, the issue of providing primary care physicians the technologies, the diagnostic tests, the availability of these tests in real time so that they can use them is going to become increasingly cost-effective, increasingly easy, because multiple companies will be providing the diagnostic tests. And will we be using this for everything? No, but we will be using it in a huge number of circumstances where we have unusual responses to medicine, failure of a patient to respond as we would want them to in terms of efficacy, as well as unusual side effects. In addition, I think what it will provide is a more rational and thoughtful way in which we can refer patients from the community to the tertiary center using the facilities and the technologies of a tertiary care center in a more rational way. Personalized medicine really comes down to understanding medicines, how they're used, and how to use them wisely, with the addition of having availability, genomic and other diagnostic tests. I think going forward, it's going to become more or less routine. However, the challenge is going to be to incorporate the teaching of pharmacology, therapeutics, and genomics, and contemporary genomics, to multiple levels of learners, from medical students, through our house officers, through practicing physicians. And we are now working at Mercy on developing educational packages and ways of communicating about advances in personalized medicine to all of these constituencies. And I should also add in, the reality of it is our patients and the communities often know more about these things than we do, because they're reading about them daily in the media, in the internet. They are, in a sense, driving some of the need for us to understand better. So it's going to be a huge educational challenge, but one that at Mercy we want to take on forthrightly, develop the educational packages, get them to people who really are interested, and evaluate those back. Is it really helping in your practice in real time? And then having world-class organizations such as the Clinical Pharmacology Division at Children's Mercy and at other hospitals around the country be the nidus to which consultation goes. Costs are an interesting issue. We know right now that a lot of medicines are being used incorrectly, which leads to failure of benefit and increased risk and side effects. The costs of that are enormous. Increasingly, the kinds of medicines that are being developed by industry, the pharmaceutical industry and others, are very, very highly targeted to very specific targets. And if the patient doesn't have that target present, that's futile therapy and costs a great deal. All the arguments about, you have to treat 1,000 patients in order to see benefit in 200 don't really make sense biologically. Biologically, we know that different people respond differently to these medicines. We want to identify those 200 up front so that they get the medicine. The 800 who can't benefit from the medicine won't get the medicine, and the medicine will be more wisely used. It's going to take a very different economic model than we now have for drug development and for the pharmaceutical industry, for the marketing of medicines. But frankly, if you look at it, what we all want is a value proposition for medicines. The right drug for the right patient, for the right condition, at the right dose. And if we can get there, in fact, the cost savings associated with that will be substantial.